My name is Ellen Mitchell. I'm a nurse practitioner student with Auburn University, and I will be presenting a 5-minute video on meningitis. Meningitis is a potentially life-threatening inflammation of the meninges of the brain and spinal cord. Meningitis is most commonly caused by a viral infection, but can also be bacterial or fungal. The nervous system is predominantly affected. Symptoms to notice with meningitis are usually fever, vomiting, headache, nuchal rigidity, photophobia, and confusion. To determine the etiology of meningitis, a lumbar puncture must be completed. Presence of white blood cells, elevated protein levels, and decreased glucose in the cerebral spinal fluid will indicate a bacterial infection. Risk factors for bacterial meningitis are infants under the age of 1 year old, the immunocompromised, parameningeal source of infection such as otitis media, sinusitis, or mastoiditis, travelers to endemic areas, neurosurgical procedures, head injuries such as skull fractures, patients living in close proximity such as college dormitories are also at risk. Incidents have greatly decreased since the HIV vaccination. Risk factors for viral meningitis are close proximity with an individual who's been infected with viral meningitis, immunocompromised patients such as cancer patients, splenectomy patients, diabetics, and HIV patients. Viral meningitis is most common in the summer and fall months. 3 major questions to ask in the workup for a patient who has suspected meningitis are: do you have any pain with the movement of your neck? This could indicate nuchal rigidity. Any photophobia, any headache, and also any fever. 3 top physical examination components that must be examined to provide adequate assessment are a positive Koenig sign, and this is when the thigh is flexed at the hip at a 90-degree angle and you have a subsequent extension of the knee that is painful. Also a Brudzinski sign that is positive, and this is when the neck is passively flexed and there's extension of the hip and knees. These 2 assessment findings occur due to the inflammation of the meninges and spinal cord. Decreased level of consciousness due to neurological changes or high fevers are also associated with meningitis. Most commonly, nuchal rigidity is examined by solely attempting to rotate the patient's neck from side to side or asking the patient to look up and down. Inability to flex or extend the neck suggests meningeal inflammation. And the most common treatments for meningitis are you want to begin antibiotics immediately until the culture is proven viral. If the culture proves bacterial, you want to begin the appropriate antibiotics. Empiric treatment for meningitis is ampicillin, a 3rd-generation cephalosporin, and a possible need for an aminoglycoside. Dexamethasone can increase morbidity and mortality by decreasing inflammation of the meninges. Antipyretics such as Tylenol and ibuprofen are also used. Analgesics for headaches, antiemetics for nausea and vomiting, and antiviral agents are not commonly recommended. Depending on the etiology of meningitis, contacts may also need to be treated prophylactically. Patients need to be referred to the emergency department and neurology with infectious disease immediately. Bacterial meningitis has an overall fatality rate of about 14%. Patients are usually afebrile by between 7 to 10 days, and headaches may persist for up to 2 weeks. The most common teaching components to address with patients are the importance to remain hydrated with high fevers, isolation precautions, and hand washings to protect the other individuals, minimizing external stimuli, specifically light and sound, elevate the head of bed to about 30 degrees, no straining with defecation, so you want to make sure the patients are on a stool softener, and avoid sneezing and coughing to avoid increasing the intracranial pressure. You want to keep the patient on seizure precautions at all times due to a high risk of seizures with the inflammation of the meninges. Hope you've learned a lot about meningitis.